Did you know that the food on your plate, is partly shaped by government policy? The subsidies that make processed food cheap, the regulations that determine what gets labeled, the trade agreements that decide which ingredients flood your grocery store. And here's the part nobody talks about. Those same policy decisions are quietly affecting how well your medications work. My guest today has studied health symptoms. Yesterday, has studied health symptoms across 3 continents. She's worked in global health governance, non-communicable disease prevention, and food safety policy. And she's going to connect the dots between what happens in government chambers and what ends up in your body. This is not a political episode. This is a patient empowerment episode because when you understand the system, you can navigate it. So stay with us. To Where Food Meets Medicine, the podcast where we explore how what you eat affects how your medication works and how your health thrives. I'm Dr. Remi Olukoya, pharmacist, and today we're doing something this show has never done before. We're talking and we're zooming all the way out from the pharmacy counter to the policy chamber. Because what I've learned is dispensing medications every day, counseling patients, watching the same struggles repeat, is that individual health outcomes are often determined by decisions made far above the individual. So in boardrooms, in parliaments, in trade negotiations. So I want to start with a patient. She was managing type 2 diabetes in a neighborhood where food produce was nearly impossible to find. Her medication regimen was sound, but her diet, it was shaped by, not by choice, but by what her neighborhood made available. It was working against everything, every dose she took. And when local policy eventually brought a farmer's market to our area, her A1C improved, not because she changed her willpower, because the system around her changed. And that patient is why this episode exists. Dr. Tosin Dotun-Olujinmi is a global health scholar, health system strategist, and public health leader. Her experience spans North America, Europe, and Africa. She holds a Doctor of Health Administration from Central Michigan University. Our research focuses on the social and governance factors driving premature non-communicable disease mortality. She's a co-founder and CEO of IDE Public Health Consulting in Canada and serves as a visiting faculty at Obafemi Awolowo University in Nigeria. Dr. Tosi, welcome to When Food Meets Medicine.
Thank you, Dr. Remy, for having me on. And thank you for emphasizing on policies, because indeed, a policy or a policy is a deliberate high level framework that guides principles. Just you did emphasize regarding the patient that's in this discussion today.
I love that. Policies are deliberate. It makes and changes and our lives in general. And as a pharmacist, I see the end of the pipeline every day. Patients come to my counter carrying the consequences of decisions they had no part in making. And the most empowering thing we can do today is help our listeners understand where those decisions come from and what they can do about it. So let's start. At the very beginning, Dr. Tosin, for most of our listeners, public health policy sounds distant, something that happens in government buildings far from their kitchen. So, from your experience working across 3 continents, how does a policy decision made in a government chamber become the food on someone's plate and ultimately affect whether their medications work?
Public health policy quietly shapes every health decision we make without us realizing it. It seems like a faraway decision, but what ends up on your plate is influenced by, for example, the cultural subsidy, food labeling laws, import and export regulations, and even urban planning that determine whether you live in a grocery store, a food market, in a farmer's market, or a fast food cluster. So, for example, like in North America, And I would say probably the United States, subsidies are often favored by commodities like crops, like corn or soy. So it translates into ultra processed foods compared to fresh products. Meanwhile, in some sub-Saharan African countries, Nigeria context where I have lived and worked, food policy challenges are less about overproduction, but more supply chain fragility, leading to limited access to diverse nutrition food. So that's on the food. So on the pharmaceutical side, we also see that policy determine which medication are approved, how quickly they reach the market or whether they are affordable, and who gets access. One example in the United Kingdom is that there's a central system, which is the NHS, and I think the National Institute for Health and Care Excellence, they negotiate drug prices effectively. So that increases access, competitive drug prices, and that's, of course, facilitates access to such drugs. But in contrast, in many low income sets, we see fragmented procurement systems, which mean essential medicine that should be accessible and not available affordably. So whether it's your breakfast cereal, your blood pressure medication, policy is making decisions before you do. So like you did mention, someone on diabetes medication, you know, glucose lowering medication, for example, they might be adhering to their medication. However, the built environment in which they live or the policies that determines what facility they have around them will actually determine their health outcome or how effective the medication works in interaction with the food they consume.
So your doctoral research I looked specifically at governance and NCD mortality. What governance failures do you see most consistently driving this outcome?
I look at what was significant in that study, actually, which was published in the Journal of Public Health in Africa, because the subject countries were six selected African countries, was the dimension of governance, which is voice and accountability, which is what can also be determined as agency, meaning the voice of the population matters. That means there is a higher chance of formulating policies that work when the population are inclusive in drafting that policy.
Yeah.
So for people, for representatives from such populations sitting at the decision table, determining or contributing to policies that determine their own health, there is a direct relationship with that involvement in that governance structure and actually a reduction in mortality associated with NCDs, specifically that
CDs, just in case
non-communicable diseases. We use that more on this side of the world, and in some space, it's chronic diseases.
Let's talk about food safety and regulations, because from farm to fork, policies shape every stage of what ends up on your plate. And what ends up on that plate will affect the efficacy and safety of a medication taken an hour later. So, from your cross continental experience, what are the most meaningful gaps in food safety and labeling policy? And what do those gaps have the most direct impact on patient health?
Food labeling, I believe that that policy helps patients or the population to be involved in their decision making, their choices of food across the board, be it in the United Kingdom, or in Europe, or North America, or in sub-Saharan African countries. It empowers. I call it more of education regarding what the population, they are aware of the content of what they are consuming and the adverse effects on their health. So I believe that like the food labeling laws are in place, to enhance decision making, to empower the population in the choices they are making regarding their own health.
So these gaps, how do you see it in the African context? I know that, like you mentioned, North America, Europe, these policies are in place. Do you see such in Africa?
In Africa, I would say extent you see some of this labeling in place. However, does it translate into a meaningful knowledge to the population? Is it emphasized upon? Because a lot of times our system is a bit different. But a lot of times we have to think of representing information in a context that is applicable, relatable. Maybe an average market woman that is not educated in a formal setting might not be able to read that label. And even if it's translated into other languages, might not be able to also read in those local languages. So how can such individual be informed about the food they have right in their hands to determine if it works for them or not or interact? I believe that we have to become proactive, which in the context of maybe Africa, and I'm talking about the general population that are not maybe the same spectrum as the individuals in that population that are comparable to populations in the United Kingdom, in Europe or North America. So we have to find a practical way within the policy system to be able to translate it. There was a time I watched a documentary on BBC Pidgin, and in terms of the food portion, like the nutritional food guide every country had, it was actually demonstrated in a visual way in the pidgin language, using the fingers. Like if you want to eat any carbohydrate base, it came with a feast, maybe one. If you want if you're thinking of a protein portion, there's just something visual. But how can that be communicated? That was like a general. And so if such can be represented, like maybe on the food label, maybe using like a feast or maybe an pictorial pictorial format for those that are not, educated in a formal way. They could understand that labeling and they will be able to make their choices. So if such policies can be rolled out, that would close that gap in systems in sub-Saharan African countries.
I like those suggestions because those are gaps that we have to close. And those gaps are what I see playing out at the pharmacy counter. And let me name specific examples that our global audience would recognize. And I know we've mentioned different continents. In West Africa and parts of East Africa, many imported ultra processed carry labeling that meets the exporting countries' minimum standards, not the importing population's health needs. So a patient in Accra or Kampala has no way to know the sodium or sugar or addictive content if they are on, an antihypertensive or diuretic. And that hidden sodium matters clinically. In the UK and the US, certain food dyes, preservatives, and maybe emulsifiers that are banned or restricted in the EU are still permitted in processed food. So some have documented effects on gut health, and gut health affects medication absorption. So a patient on warfarin or tacrolimus whose gut microbiome is disrupted may see unexpected fluctuations in their drug levels. And then I know across South Asia or Latin America, the heavily marketed sugary beverages with regulatory frameworks that lag behind this evidence and directly driving insulin resistance, and they're making diabetes medication less effective over time. So what does effective food safety governance look like? And which countries or regions are doing it well?
So you mean looking at governance and health outcomes?
Yes, yes.
Okay. Generally, we should understand that governance is a backbone of health outcomes. I think once that resonates in our mind, even as policymakers, this approach is taken carefully. You know, those governance, which means governmental, enterprise or organization, they need to create a transparent system that is accountable and effective. You know, you have those in place, it translates into stable food systems and reliable access to medicine. When such gaps are in place, we could see here that cracks had shown in the past, like low medicine procurement. We did see there there wasn't access to the vaccine in time.
Mm.
So is it financial capability? Probably, but I would associate it to maybe of some form of weak governance because we could
Yeah.
see that that's being addressed currently and there's a change in that landscape already. We see a lot of counterfeit drugs when there are weak governance in place and poorly regulated food environment flooded with unhealthy options. We did mention who are the gatekeepers of drugs that are imported, into every space. Right now in Tinkan, one of the most popular port of entry in Nigeria. So when we talk about those port of entry, there is a zooming in now on imported food that are high in antimicrobial, testing for because of antimicrobial resistance occurring in the population. So those food products, the meats especially, are being tested that are high in antibiotics. In many low and middle income countries, governance challenges could mean even policies that appear on paper, but are not consistent or lack implementation. And that indirectly or directly affects health outcomes. So we can have a national essential medicine list as a country, which is really always recommended by the World Health Organization, but with procurement systems or even corruption. Who are the people getting access to that and, start tracking it from the general markets? And those medicines are not reaching the population or the clinics that are really in need of it. So good governance ensures that policies just don't exist, but they actually work for the people. So going back to that architecture for policies, and I think at the back of formulation of every policy, the thoughts has to be there that would this eventually work for the people, the general population? Would this actually translate to better health outcomes?
Think a model where you have a policy, but it still transcribes to real life, and it could be good on paper, but is it good in? So, for anyone who wants to understand food interactions with their specific medications, regardless of what the label says, my MediMeal Safe app checks any food against your medication in real time. You can check at pharmaplansystem.com, and the link will be in the show notes. So, Dr. Tosin, the other side of the equation, the medication itself. Food policy is only one half of this story. The other half is whether patient can access the medications they need at all. So why do some communities and some countries have dramatically better access to essential medicine? And what is the governance story behind that disparity?
I would say affordability, we do always look at health financing and the healthcare structure or healthcare system in every country differs from one to another. The United Kingdom is universal healthcare and the government owns the hospitals, they own everything, which is different from Canada. Canada is more of transfer of funds. So in the United Kingdom, if you are a citizen or a resident, there's a chance that regardless of your status, you would have access to medicine.
Yeah.
Because of now coming back to Africa, I won't generalize because there are 50 plus countries in Africa. But let's look at Nigeria specifically. There isn't like a universal health coverage in a country like Nigeria. It's more of out of pocket system predominantly. There's still now I heard that Lagos State is rolling out some form of healthcare insurance, but talking generally now, they are not there. The nation is not there yet in terms of universal health coverage and also access to medicine. And policies might be in place, but I'm not aware of a strong implementation that control access to medicine, like a weak governance shows in poor regulation. In the open market, you can find antibiotics and still who's guiding that. So you do see that they have access to medicine, but in a concerning manner because the individuals administering the medication are not knowledgeable. They are just, typical uh, entrepreneurs, in the market. So I would say in systems like Nigeria, you just have people who have access to medicine. Now they have to out of pocket. There's a high chance of counterfeits, expired drugs, which in terms leads to poor health outcomes too, because there's no guidance, like it's your field, in terms of side effects, interaction with drugs, and even how how sure or how educated are population in terms of the knowledge in which they are approaching to access those drugs. So that's just my overall breakdown.
I know from the patient on a rationed insulin whose diet is
Mm.
also high in refined carbohydrate is in a double bind created by policies. So when generic medications are delayed because of intellectual property disputes in trade negotiations, or maybe patients in Nigeria, Ghana, Kenya, Brazil, they wait for years for the affordable version of a drug already standard elsewhere. And that waiting is not a medical problem, it is a governance problem. So, from your work, advice health systems, what are the policy levers that actually move the needle on medication access?
The policy needle.
Yes, like if based on, let's say that the drugs are not moving to generic because of lawsuits or disputes, are there policies that can actually move those needle where those that need those medication access can get it earlier and don't have to wait for a number of years to get those medication?
Yeah, well, I would say that on my part is looking at the policies in place.
That or they can be put in place, policies that can be
Yes,
put
so
in place.
now I would say there shouldn't be a one size fits all solution. Yes, we have to first, I think there's a need to understand the local health system, which I always emphasize, the strength of that health system should be understood properly, the bottlenecks, which you did mention, and of course the governance structure. So once these are understood, policies should be designed based on using data to guide decision, meaning you just don't formulate things, and also those policies should ensure that vulnerable population are not left behind, like we did mention, like pushing for policies that will help to enhance production of generic drugs that will be affordable by the the vulnerable population of the marginal ones. And those policies must be practical, not just aspirational. Because a lot of times we have to look at policies that the implementation is visible.
Yeah.
Honestly, if we look at a practical world and you have to look at your environment when that as a governance expert that being drafted to enhance access to medication. So these policies have to emphasize frameworks that is accountable, clear indication, in terms of timeline. There should be a monitoring system in place, and of course, always stakeholders engagement. How visible the pharmaceuticals, even the population representation, representatives from the population, individuals that matters must also be engaged in drafting these policies. So we should understand that strong policy is not just about writing documents, it's creating systems that deliver results, that will deliver the intended results. So we should keep that in mind.
Size does not fit all. I like that. And I think that's a level most advocates overlook. And I think the one that should reach people the fastest and should be put into consideration when policies are made, that, every society, every community is different. Every country, every continent is different, and access should be available to everyone, regardless of a country or community or continent. Also, for anyone wanting to understand how their food choices support or undermine their medication, my book, Foods That Clash with Your Prescriptions, it covers about 85 medications in plain language, is written for patients everywhere, regardless of what their health system provides. So, pharmaplansystem.com, you're going to see the link in the show notes. Excuse me. So, We're going to talk about empowerment, Dr. Tosin. This you advocate for one health approach, the idea that human health, animal health, and environmental health are inseparable. How does one health thinking change the way we design food and medication policy, and what does it mean for the patient at their kitchen table?
I would like to emphasize that One Health had been in the dialogue in recent years because there's an understanding now that human health is deeply connected to animal and the environment. Yet, there isn't a lot of policy that, I would say often there are a lot of policies that still treat this separately, like in silos. So I did mention earlier about the antimicrobial resistance is a perfect case. Overuse of antibiotics in livestock directly impact human health. I mentioned the testing that is ongoing on every imported animal food that comes into the country on the level of antibiotics in the meat, because indirectly it's been leading to a lot of antimicrobial resistance within the population. The consciousness of policies in agriculture, use of antibiotics in livestock should be interconnected with human health. Yeah. When we design. So without integrated policies, you can't effectively address this problem. Yeah. You know, climate change is another one, reshaping food systems, whether we like it or not. In Canada, it used to be like how many centimeters of snow, 8 months in the year. Depending on where you live, such is not the case, So we see, this year, for example, in Canada, in Ontario specifically, farmers are excited because we have like longer winter and it's supposed to be a lot of rain in the spring. So definitely crop yields, would be favorably affected. Yeah. And the fire outbreaks, I think it happened in some part of Canada and I think in California. Thanks. Yes, it did affect food production and food prices kind of hiked up. Yeah. And then, of course, we can talk about the nutritional quality. So policy needs to integrate environmental sustainability with food security strategy. So I would say that moving forward, and I think it's already in the dialogue because I've attended One Health conferences, government across sector need to collaborate. We can't afford to work in silos anymore. Yeah. And I really admire your podcast, really bringing the food industry and pharmaceutical together. And because that collaboration between departments is actually what brings about effective measure like those health outcomes. Concerning One Health approach, there should be a collaboration between agricultural health and maybe the environmental. Yeah. And even trade, rather than in silos. And I would say environment because a lot of times we don't really consider that. Do we have an environment where physical activities are promoted or intentional about, on that when it's being designed or redesigned or structured that indirectly leads to better health outcomes. Okay. You don't have to think of I could remember years back. Actually, after my family left the United Kingdom, we went back for like 3 weeks, and it's amazing because the system is designed such that you drive less and you have to work. The physical activity, which is already built into that environment. Yeah. We coming back, we all look trained. We didn't have to intentionally go to the gym. Yeah. Sometimes you forget that. And in countries like Netherlands, they do a lot of bike riding. And so that built environment, I think for the One Health approach, there should be an intentional approach in a collaborative policy design that will bring those departments together.
You mentioned a lot, so I'm going to touch a little bit on some of them. More, these conversations should be had. It's things we should have been having, to create awareness. The climate change, the antimicrobial resistance that a lot of people don't think about. And, that chain is from farm policy to antibiotic failure in one patient. So it's One Health in its most direct clinical expression. So, Dr. Tosi, I know you focus heavily on social determinants. You've mentioned a bit of on health. So the phrase is often quoted but rarely explained in a way patient can act on. What social determinants most directly, I know you mentioned climate, affects whether someone can eat well and still take their medication consistently?
Say education, you can never overemphasize that. Let's say educate, educate, educate at every level. And when a patient is informed about their choices, their their health, then they can make the decisions that are beneficial to their health. So I would say education from every, across every level, the formal setting, right from elementary kindergarten, you can incorporate that into policies, educational policies at school, just like maybe physical activities emphasize. Most schools would encourage parents to maybe include two healthy snacks in their kids. But how is that being taught to the children themselves? Because once they're empowered from young, it becomes a lifestyle. That's in a formal setting. But I believe that if policies are out there that intentionally look at population generally and study the demographics and design pathways to really inform those population based on their levels, I think that would be the greatest empowerment that any government can roll out. Yeah, I do agree. I know earlier you'd mentioned, which I like, that when you were in the UK, how it was part of a lifestyle to work somewhere where there's a connection between where you live and activities, how you live your life. And when you had to get to Nigeria, it was a part of life. It was normal to work. And I think the connection also should be said between postcodes and prescriptions. I think a patient in a food desert, whether in Lagos or Kentucky or South London Tower Block or a remote village in Ghana, you're not making free choices about their diet. They're making constrained choices within a system built around them. And that system was built by policy. It could be income, transport, housing, education. These are not lifestyle factors, these are health determinants, and they shape whether a patient can afford fresh food, if they can get to a pharmacy, if they can read a medication label, which is important, or even take a day off when they have a side effect of a medication. And I know that knowing this matters because patient empowerment is not just about information, it's about advocacy. You'd mentioned that earlier, Dr. Tosin. So, what can an individual patient or caregiver actually do in their system, for advocacy? I believe that as much as possible, individuals can volunteer to, be part of a board decision. It can start from your local community. It doesn't have to find forum to speak. Find a space to advocate for things like this. Write a letter to your municipal representative. Do something within the for caregivers, they can do the same thing, advocate when they take their patient in for care, at every level. Your voice matters. And I think that is what every individual have to understand. You might not find yourself directly at that level, but somehow when you continue to speak, especially in this era of social media, you never know how whatever you share in a constructive and appropriate manner can be be embraced even at a space you least expect. So I would say let your voice matter in every space. Speak, speak. I always say in my earlier career, I worked with a director who was my mentor, and she was soft spoken like I am. And I can remember she would say to me, you need to be heard all the time. So I would say the same thing. Your voice matters. So at every level, just continue to advocate. Something had worked for you, you've had any experience, you could share that. And it can be from your local community to your state, to your own little blog, to a social media space, in any way. Just find a way to be a voice that matters.
Be heard, be a voice, because that's really the answer I wanted every listener to hear, that you matter and your voice is important. You're not helpless. Advocate for yourself, empower yourselves. So, Dr. Tosin, that you can have actual food access. There's a Medi meal plan where you can create a food that works for you based on your health condition, and it's available for Nigerian cuisines, Caribbean, British, whatever your kitchen looks like. But the link would be in the show notes. So, Dr. Tosin, we're going to go to a segment that I like. It's called Rapid Fire. Are you ready? Okay. Okay. Okay.
Yeah.
So the first question, one public health myth you want to retire forever.
That I would say a lot of people think their health is their personal choice. But like in reality, as we discussed earlier, it's shaped by our environment and policies. That's why your voice matters.
True. If you could change one global food policy overnight, what would it be?
I would say access to I would say essential food, which I mean like maybe it's really nutritious meal a day. Any average family or individual. I think it's essential. Those are big fundamental needs of life.
The most surprising thing you've learned from working across three continents on food and health.
There's a huge health disparities. And I think that exists the same way in lower income countries or lower middle income countries and the welfare countries. Health disparities is a reality in all those spaces.
Your favorite healthy food that you genuinely enjoy eating?
I would say, well, now the African have been planting chips. Yes,
I
because it's less calories, especially when it's not fried, just maybe grilled.
the social determinant that mostly directly affects whether someone takes their medication in one word.
Medication. Antibiotics is a prime example. People take it after 3 days, they're okay. And they quit taking that medication. But when they're educated, and a lot of them miss it because they don't know. They think once they're applying, they can stop.
Yeah, very important. I think the last doctor on the show said exactly the same thing. Antibiotics, finish your dose. Best example of a public health policy that actually worked from anywhere in the world.
I would say at universal healthcare, and we've seen that had dramatically improved health outcomes over decades. I think initially we shared about our experiences, in the 1980s, where in every locality you have a health center.
Yeah.
Drastically, there was a reduction in child mortality rate because, containable health situation were easily contained within a short period of time. And I would say universal healthcare, and it's part of the sustainable developmental goals to see an increase of that so that individuals or population should be able to access healthcare without financial difficulty at a point of care.
Yeah, I do totally agree. Totally agree. One thing every patient should ask their government representative about food or medicine, what would it be?
Especially with your work with this podcast too, it's policies that build an interconnection between food and medicine. Since there is an interaction, I believe they should go into policies too. So there's a need for that interconnectedness. And individuals, representative advocates should be able to emphasize that.
Definitely not argue against that. So complete this sentence. The most powerful thing a patient can do in a broken food system is.
Find a food replacements that still meet the individual's nutritional needs.
I totally agree that regardless of social status, you can get a food that is available and healthy for you. If there's one message you want every patient and caregiver listening to carry from this conversation, what would it be?
Let two things know that you can be a part of policy, like we did mention, let your voice matter. And also the understanding that your health outcome is not just your personal decision, it's interconnected with your environment, your food, and, your own personal choices. And I think above all, like this podcast is all about whatever you can at every level, you can make that informed decision, understanding that your your nutrition do affect how your medicine works. So living here, I think everyone listening, or being a patient or a caregiver, have to understand that there's an interconnectedness between these two. And there is a greater or higher hierarchy that determines how things work to make you, to help you desire.
I think this is the perfect note to end on. And I want to thank Dr. Chosi. I think it's very, very important for every listener to take from today that the food on your plate and the medication in your hand did not arrive by accident. They arrived through a chain of decisions about subsidies, trade, labeling, about access, made long before you even walked into a pharmacy or into a supermarket or grocery store. So understanding that chain does not make you a victim of it. It actually makes you a more informed navigator of it. So you can ask your pharmacist about the interactions between your food, environment, and your medication. You can ask your doctor about how your neighborhood food access affects your treatment. You can vote. You can advocate. You can organize around health equity. And you can start today. So with the food you choose within your constraints, which Dr. Tosin mentioned, question you ask at your next appointment. With this episode, share with someone who needed to hear it. Dr. Tosin, thank you so much. Your work sits at the intersection of the most important questions in global health. You made it land today in a way every listener can feel where you people can where can people find you and learn more about ID.
Yes, although based in Canada, I work internationally with NGOs. You can connect with me on LinkedIn. You find me, Dr. Tosin, and from there you can connect with ID as well. So you can search me up on Google. The website is next at www.id.org. And if you want to connect with me personally, I have an active LinkedIn profile, and you can also connect with me via my podcast and my publication.
Okay. So we're going to have Dr. Chosin's information in the show notes, everywhere you can reach out to her. So before we go, I want to talk about three tools from pharmaplansystems.com. The MediMeal Save app, which checks any food against your medication in real time because your food environment shapes what is safe for you to eat. My book, Foods That Clash with Your Prescription, it covers about 85 medications in plain language, written for patients by a pharmacist, navigating real food systems, not ideal ones. And the MediMeal plan, it builds a personalized eating plan around your medications and your actual cuisine, all at pharmaplansystem.com. It's going to be in the link in the show notes with Dr. Chosin's information. All our details and ID Public Health Consulting would be in the show notes. To everyone listening in Nigeria, in Canada, the UK, the US, and everywhere this show reaches, thank you. Thank you for caring enough to understand the system that shapes your health. That understanding is the beginning of change. And if this episode helped you, share it with a patient who thinks their health is just about personal choices, with a caregiver who does not know why the system makes everything harder, and with a clinician who wants to understand the world their patients are navigating. So subscribe on Apple Podcasts, Spotify, YouTube, or Amazon Music so you never miss an episode of When Food Meets Medicine.